We have two shorter lectures today, right? So we're going to cover cervical and migraine presentations. We're also going to cover um, cognitive presentations as well today. So, pardon me, these are two shorter lectures, but we are going to go ahead and just kind of do both of these today. So they should not be anything that's going to be uh, too difficult. All right, so let's actually start with cervical and migraine presentations, and let me um, share my screen, and we'll go to the slideshow tab. Perfect. Okay, guys. So as we've kind of talked about, right, there are actually there are different clusters that concussive symptoms can fall into, right? We've talked about ocular, we've talked about vestibular. Now we're going to go into basically cervical slash migrainous presentations. Okay, so as we talked about, remember that we said that with the SCAT5, it is not uncommon to see people reporting the same symptoms over and over again, right? Oftentimes, we will see patients um, consistently reporting things like neck pain, headache, these types of things, right? Stiffness in the neck, all of this, and maybe even a little bit of light sensitivity, pressure in their head, pain, pressure behind the eyes, these types of things. Okay, so definitely possible when we see these types of things that this could be due to some sort of a cervical pattern. So as we've already talked about, right, normal recovery from concussion, generally within 10 to 14 days in the athletic population. Some people say even up to a month. But the bottom line is that once we get outside of a month, okay, once we're more than 1 month post, right? That initial injury, we have what's called a protracted recovery, and the patient is essentially can be diagnosed with what's called post-concussive syndrome, which essentially are just continued concussive symptoms that fall outside of the normal recovery window, right? Does that make sense to everybody? The way that I say that? Okay, cool. You guys have questions? Stop me. Okay, let me know. All right. Okay. Here's the deal. So when we talk about obviously cervical causes of headache, right? Um, there are a lot of different factors, and we're going to see a slide here in a second that explains some of the anatomy, right? But cervical, causes really are one of the can be one of the main causes of continued symptoms post concussion, right? And generally speaking, as we've kind of seen with with those higher impact mechanisms, right? That if that causes obviously the cervical spine to hyperextend, we get the coup contra coup mechanism, right? And there are people that actually think that the reason why we see so many cervical issues post concussion is due to basically whiplash, right? That hyperextension of the cervical spine at the moment of impact that causes a lot of these symptoms. Now, the upper cervical spine and really so C1, C2, and then part of C3, and we'll talk about that in a second, right, is generally the part of the cervical spine, right, that we see most commonly implicated in headaches, right, and continued symptoms due to how the nerves actually travel, right. So if you guys remember, right, when we talked about the brachial plexus, literally the brachial plexus was C5 through T1, and all of those nerves, right, all of those nerves traveled from the neck and the arms, right, and provided us with sensation and motor function to the upper extremity. But okay, when we talk about C1, C2, and then C3 and 4, okay, those first four cervical levels, the neurological the neuroanatomy of how those of those dermatomes and how those uh, nerve roots provide sensation and motor function is different, and we'll see that in a second, right? So a lot of this is at least purported to come from the upper cervical spine. Bye, Charlie. I think Charlie left. We lost him. He'll be back though. All right. So obviously, referral from the upper cervical spine can result obviously in headache, neck pain, and stiffness, right? So here's kind of what we're talking about. Okay. If we look at the anatomy, all right, of the upper cervical spine, right, versus, for example, versus um, the the brachial plexus, what's one of the first things that you notice about how this is laid out compared to what we know about, you know, C5 through T1?
I mean, and just looking at it, it looks fairly similar, but has its, I don't
Okay.
know.
What
Looks
do you
similar, but
notice
like I
though?
can see it's different. I don't know if that makes sense.
Okay. So Bennett, what do you notice though if you look at that at C1 to C3? What do C1 to C3 do that 4 and 5 don't?
Like it's a loop.
Okay, it's a loop. Okay, right? Yes. Okay, it's a loop. But the bottom line, right, is that when you have a potential, also obviously compression and or involvement of C1 through C3, right? Ultimately, it's not uncommon to get pain referred not only into the neck but also up the back of the head, around the ears, right, into the forehead, and we'll actually see that in a second. Okay, so the other thing that we can also see, right, is the close proximity here of these nerves to the vertebral artery, and we're actually going to get into that when we talk about the cervical spine after spring break, right? So, but yes, the anatomy, honestly, is different, and nerve roots C1, 2, and 3 communicate with each other, right, through this neural network, right? So there is a lot of anatomical crossover, right, between these levels, because they actually have shared innervations. Okay, all right. Now, here's the deal. Okay, when someone comes to you and says that they're having a headache after concussion, right? um, Particularly when those symptoms are protracted, the one thing we should ask them is where, right? If they say my head hurts, ask them, okay, well, where? Is it more like in the front? Do you notice a lot of your symptoms kind of on the side or the back of your head? And what seems to make it better or worse? Does anything make it better or worse? Right? So oftentimes what we'll see, okay, if we have somebody that has, um, like a cervical cause to their migraines, maybe it actually has restriction at C1, C2, in C3, right? Or maybe it's just a ton of trap and sternocleidomastoid tightness as well that could be contributing. But it's not uncommon to see that people that have cervical etiologies for headache and for pain will very often have pain referred to the back of the head, right, around the ears or eyes, right, and then into obviously the frontal portion of the skull as well. Okay, if we think back to your neurocomp for a second. What do we remember about dermatomes C2 and 3? And if there's involvement there, how could that explain some of these referral patterns if you think back?
Like just because C2 and 3 are on the face, like is
Okay,
that what
yep,
you're getting at?
yep. And if you remember, right, our dermatomes for C2, so top of the head, periauricular region for C3, okay, pectoral girdle for C4, right? Okay, nice job. Does that make sense?
So like you're getting at like based on the location, we know off our dermatomes like what nerve root might be affected is what you're getting at.
Correct, right. What nerve root might be affected, and that's going to help us as far as targeting interventions, right? How do we potentially fix this? What do we do? What things do we have at our disposal um, to treat? And so that's when we're going to use, things like maybe manual spinal traction, some joint mobilization of the cervical spine, those types of things. Okay. And those are things that I will teach you. You probably have already learned some of that though with Marion modalities, I'm assuming. Um, so, but we will review it and go over it. Okay, here's the deal. So sometimes too, okay, one thing that is not uncommon to see in patients that are having just persistent headaches after concussion is migraine. Okay, and I think all of us have heard of migraine, and we know a little bit um, about migraine, but we need to actually define migraine a little bit. Okay. So migraine, right, is basically a temporary and resolving headache condition, right? And we have two types. Okay. We have migraine with aura or migraine without aura. Okay. So migraine symptoms, generally speaking, are generally always unilateral in nature. So generally affect one side. Okay. Um, of the body. And people will often complain of like, really weird symptoms like maybe even tingling, maybe even numbness. And so sometimes if we don't, sometimes if it's someone that really doesn't have experience with migraines, it's really important to just make sure that there's no other, obviously, other neurological pathology like stroke or TIA that's happening, and we can rule that out by just doing a quick cranial nerve exam, right, and just checking distal strength because that should be normal in somebody with migraine. Okay, does that does that make sense, or is that confusing? Okay,
I don't know.
I think that makes sense. Um, do you have a question, Ben, or no?
No, so like aura is what?
Yep. So aura essentially, like someone may have a migraine and they may come in and tell you, yeah, my face is numb. I can't feel the right side of my face. Right. You may notice, and we'll talk about this in a second, okay, altered pupillary response and maybe even some speech deficits in somebody that's having a migraine. Okay. Now, here's the thing. How do we, okay, if we notice those types of deficits, right? How do we know that it's a migraine and they're not having a stroke or a TIA, something like that? How could we rule that out clinically? What do we do?
You said do an exam, uh,
Do
cranial
an
nerve exam.
do an exam. Okay, cranial nerves should be relatively normal, right? Distal strength should be intact, right? Does that make sense? So and the other thing, take a careful history. Do they tell you, yeah, I have a history of migraines. This happens all the time, right? Or if they tell you, I think I'm having a migraine, but I'm not sure. Never really had a history of this, right? And you notice cranial nerve deficits. You notice weakness, right? You might need to refer them just to make sure that there is no other excuse me, no other neurological pathology that's going on. Okay. Does that make sense? Okay,
Yeah.
cool. Um, so one thing that often defines migraine is also the presence of essentially photophobia or phonophobia, right? Which is essentially sensitivity to light or sensitivity to noise. Um, so there is, as we'll see in a second, a vascular system called the trigeminal vascular system that has been implicated in migraine, right? And so medications that treat migraine, like Imitrex and these other types of things, are meant to essentially promote vasodilation within the brain and actually vasoconstriction, and um, essentially, assist with migraine symptoms. Okay, so there is a mechanism, right, known as the trigeminal vascular system, right? So this essentially is, at least right now, believed to be, right, the physiological mechanism that is involved in people that get migraines. Okay. Um, so the trigeminal vascular nerve, I'm sorry, the trigeminal nerve uh, communicates with essentially vasculature in the brain, right? And the trigeminal nerve actually regulates the diameter of the cerebral vasculature. And a lot of times, right, in people with migraine, they can have a little bit of misfiring of trigeminal nerve 5. By the way, if somebody's having a migraine, okay, and let's say that the trigeminal nerve is misfiring, right, and causing essentially altered hemodynamics, right? Why would it make sense that someone with migraine might have facial numbness? Think back to your cranial nerve exam. What does the cranial nerve, or what does the trigeminal nerve do?
Facial sensation.
Yeah. Okay. Very good. Um, so obviously, guys, this is really, really what we're doing. If we know our cranial nerve exam and we know it well, right, we can build in these little layers of difficulty, right? in detail to kind of continue to kind of critically think, right? Okay, so it is those vascular changes that essentially have been attributed to things like, aura, like facial numbness, right? Light sensitivity and phonophobia. Now, some patients with migraine also, may have difficulty exercising, these types of things. But the bottom line is that in someone with persistent headache post concussion, um, we do, we it would we need to keep the presence of possible migraine type symptoms in the back of our minds, right? And there are medications that can be utilized, to kind of help treat those types of things, right? So, and it's also not uncommon to have some nausea and vomiting, right, with migraine as well. Okay, so how do we treat? Okay, how in the world do we treat cervical presentations? Okay, of um, concussive symptoms. So we can do things like cervical manipulation, okay, mobilization, and proprioceptive training. And I'll actually introduce some of that stuff to you guys right in the coming weeks as we start getting into like rehab for concussion treatment and rehab. Um, so also it's also not uncommon that you may have to refer these people to either maybe like a headache specialist and or a neurologist, right? Um, there are times where people will actually do injections, right? Upper cervical blocks to actually kind of help with cervicogenic headache, right, referred to the back of the head. Um, and there also are obviously medications that we can use. First and foremost, okay, our choice, right? Our choice um, with for at least over the counter is we're going to use Tylenol right out of the gate, right? Why would we utilize Tylenol instead of NSAIDs, particularly in the early phases?
Because, well, in this case, we don't want the blood to get thinned, but it's more so to let the inflammation process happen.
Okay, okay, yeah, and really, right? So we obviously, yes, we don't want to thin the blood, but that's something that we can do pretty much over the counter, right, for people that are having persistent symptoms. Um, there are two medications here that you guys will probably hear about a lot and maybe even see. Okay, amitriptyline, okay, is a medication that's used for migraine, specifically for headache, right? And that is a medication that you can that when you have a headache coming on, you simply take that medication, and it causes vascular changes, right, within that vascular system, um, and
Wait,
can and alleviate symptoms.
is that
Another one that you got. Yep.
like Excedrin migraine? Is that the same thing? Okay.
Similar, yeah. So this though, Izzy, that's a great question. This
Okay.
is prescription. Okay, so it's similar to Excedrin. Excedrin, the one thing that makes Excedrin different for migraines is Excedrin actually has caffeine, right? And so caffeine can also cause those vascular changes, right? That can treat migraine over the counter. Okay, but you know, as far as prescription goes, we'll see that with amitriptyline. Now, Izzy, you ask a good question, and and this is really more of an organ type thing, but and one thing you guys see down here at the bottom is occasional use of NSAIDs. Now, if you're writing a policy for concussion, okay, one thing that I would really recommend that you do is um, talk with your supervising physician, right, and talk about situations like maybe in the presence of migraine, where it might be appropriate to utilize something like Excedrin and or maybe even an occasional NSAID. Obviously, we wouldn't do that acutely, but on a case by case basis, it might make sense. Does that make sense? Okay. Now, another medication that we have listed here, and the reason why I'm kind of explaining this to the degree that I am, because it's very common to this is a very commonly utilized medication, gabapentin. Has anybody heard of that before? Gabapentin. You guys have had Farm, right? Okay. Gabapentin is a neuromodulating medication. All right. Gabapentin was initially utilized as a seizure drug. Okay, but it has multiple uses that we found over time, like treating headaches, right? The one thing with gabapentin is that gabapentin can make you very, very drowsy and very, very sleepy, right? So really only take that during the day. I'm sorry, take it at night. Don't take it during the day. Jeez. Okay. If you have a lot of drowsiness with it, take it at night. Now, we used to, when I worked at TRIA in the Total Joint, we also used to use gabapentin as essentially what's called an opioid sparing medication, right? So we would utilize gabapentin as a part of the pain management plan to essentially decrease the amount of tramadol and oxycodone that patients were taking post-knee replacement. So anyway, gabapentin is a really important medication to know about. Okay. All right. So that's it for this one, guys. Give me a second. I'm going to get set up for the next one. All right. And then we'll get rolling. Any questions about what we covered so far? No? All right. You know what, guys, if you give me 2 seconds, if you guys need to take like a 2-minute break, feel free. My dog is being annoying and thinking he needs to go to the bathroom. I'll be right back. Okay. Take a break for a second. This next PowerPoint is like 6 slides, so it's super short. Okay. Be right back.
Wade, your mic's off.
Sorry. Okay. That's all right. I will resume talking. Sorry about that. Okay. So when we talk about obviously cognitive profiles, guys, this is the area where we really have to use our best clinical judgment um, and have available resources to be able to refer. Okay. When we talk about, obviously psychosocial concerns and anything having to do with that area of care, right? The role of the athletic trainer essentially is to identify and facilitate referral, right? While it's true that yes, we do, sometimes take on the role of counselors, and our patients come to us with all kinds of problems in life situations, yeah, that's definitely part of it, right? But when it's necessary, we need to have a low threshold for referral, and have the available resources, whether it's campus counseling, uh, excuse me, whatever it is. Okay. So obviously, I'm not going to belabor this, but we know that at this point, we know that the post concussion symptom scale, ad nauseum, 22 possible symptoms on a scale of 0 to 6, right? But there can be those symptoms that can essentially fall into essentially a cognitive presentation, right? Headache, right? Headache is a multifactorial symptom, and so we need to be a little bit more thorough, right, when trying to essentially nail down not only location of headache, but what makes it better, what makes it worse, right? Uh, Light and noise sensitivity, right? Things like feeling slowed down, fatigue, drowsiness, feeling mentally foggy, difficulty concentrating, and difficulty remembering. So particularly, right, the feeling slowed down, fatigue, drowsy, these types of things, right? Those are all things that people with clinical depression, these types of things experience, right? So they actually have these somatic symptoms that can present as a part of that as a part of that pathology. Um, all right, so we know, right, that as we talked about before, we do have these concussion modifiers, okay, that can essentially make it more difficult for someone to recover after a concussion. Okay, um, so those concussion modifiers obviously can affect the length of recovery. Now, obviously, we know that a big one, okay, is the previous history. We have to ask really good questions about how many concussions have you had in the past. Okay, and like we said, it's not just the number; it's how long has it taken you to recover with each subsequent concussion, right? We also know, okay, previous history of migraine, okay, learning disability, dyslexia, ADHD, or even now autism, right? There's now kind of increasing amounts of research that essentially state that ADHD and autism are actually on a similar spectrum, right? Also depression, anxiety, other mental health concerns, right? Uh, Anyone that has those types of things in their history previously, these things can be magnified after concussion. So be very aware, right? And know that if you have someone that's on medication for ADHD or any of these types of things, that that it may take them a while to get better. Okay. So obviously, like we've talked about, recovery past 14 days, parentheses 1 month, right? Depending on what you read, is termed protracted. Okay. All right. So obviously, um, with concussion, right, there's been some emerging research about whether or not we can actually try to predict whether or not someone will have a protracted recovery. And in this study, right, they actually found uh, essentially correlations, obviously, between headache severity and cognitive and fatigue symptoms. Okay. Um, and really, the the point of this study is that they were looking at when somebody reported concussion, right? And so essentially, in those that sustained a concussion and were evaluated less than 1 week after the concussion, right? Uh, symptom scores, higher symptom scores in the areas of headache, cognitive symptoms, and fatigue were predictive of a protracted recovery, right? But in those that were not evaluated until 1 week to 3 weeks after concussion, uh, you know, there were higher scores in things like anxiety, depression, feeling irritable, feeling more emotional than normal, right? And those people were likely to have a protracted recovery um, when evaluated after when those symptoms were present and evaluated after a week. Okay. Now, like we talked about, right? It's really, really important to know your patient. Have a good, particularly, having a good baseline and knowing what is normal and what's not normal for them, right? Um, so, it's sometimes stop it. Sometimes cognitive symptoms may be pretty subtle, right? Um, the um, so the presentation of cognitive symptoms sometimes can be very like abrupt, like people will after and you'll actually see this occasionally on the field. Somebody takes a blow to the head, and then they get super pissed off. They act like a crazy person, right? They might be really irritable and combative, but sometimes those cognitive symptoms may actually result in people becoming more withdrawn, right? Um, so when I was working on my doctorate, I did a small scale qualitative study on patients that had had a history of concussions, and we kind of talked about how those symptoms actually affected their life on the daily. Okay, and we'll talk about some of that in a second. But some people with concussion can kind of show these kind of depressive traits where they really don't want to be around people. They might withdraw, just kind of shut themselves in their room, um, and maybe either sleep and or just kind of lay in bed or what have you, right? Um, and you may also notice after concussion sometimes that maybe like let's say that you work in a college university setting, and you kind of have an idea of who their friends are, maybe their friends on the team, those types of things, and all of a sudden you see that those established friend groups, that they're not really hanging out with those people anymore, or that you don't really see them around, right? And so it may kind of lead you to have a little bit more of an intentional conversation, um, and potentially discuss the possibilities of referral. Okay. Okay. So this is just a snippet really of a study I did when I was working on my doctorate, right? And these are three actual real people, um, and these are people that had all had a significant history of concussion previously. Um, so two guys and one lady, right? And they all of them kind of had different life situations. They were kind of talking through symptoms when it came to concussion. So one of the things that I actually saw is that people, right? And I don't know if you guys have seen this or maybe even heard this, but there still is a lot of misinformation, right, in regards to concussion, in the sense that at least what we found here is that for people thought that they didn't have a concussion unless they had like all possible symptoms: headache, dizziness, light sensitivity, mood changes, the whole thing, right? They didn't necessarily think that they could maybe just have a headache, right, or just kind of be forgetful and have a headache, right, and that could be a concussion, right? So they had a tendency to ascribe, right, all 22 possible symptoms, um, on the SCAD-5 as being what defines concussion versus not, right? Um, they also obviously noted that the way that they felt obviously affected their mood, right? There were definite changes in how they in their socialization and how they kind of related to people, right? Some memory issues, and then obviously they also voiced concerns about obviously uh, their symptoms affecting them down the road. So uh, yeah, so basically it's kind of what we found, right? So a lot of people have they tended to develop, particularly psychologically, kind of this increased fear, right, of subsequent concussion, but also um, a little bit of paranoia, right? Um, and then ultimately, this actually did affect their self-concept and actually led to a little bit of depression. And these are actual quotes from people, right? And this is one of the guys, and he essentially basically said, and not to read this off to you guys, but he said, that I would say that since I've had concussions or more concussions, that he said, he feels like he's been more on edge, right? So like even after a play in practice or a game, right, always just kind of wondering, if you took a hit, do I have a concussion? And really kind of um, really kind of bringing on a lot of like anxiety, like at least within himself, right? And then he says that just within the culture, just around his team, that he knows that if people have had concussions, that they're going to be essentially afraid of getting another one, right? And that's always going to be something that's in the back of their mind. um so for any of you, by the way, and you don't really have to share personal details if you don't want to, right? For any of you that have had concussions in the past, does any of this like resonate with you, and if so, how?
I mean,
Uh,
I guess I always think of like the long-term effects because there isn't a lot of like research out there on how it affects you like long-term. And when I had like probably my worst concussion when I was a junior in high school,
Yeah.
I definitely like felt a lot more slower and that it
Yep.
took me to kind of like understand some of the things that I was being taught. And like obviously my attention span wasn't as long as it used to be.
How long did it take you to get better after that?
Probably I think it was like 2 weeks or so
Okay.
of
Okay.
like completely no symptoms.
Right. So, Drew, I have a question for you as a football
Shoot.
player. Okay. So, and you don't have to. You don't need to throw anybody under the bus. But my experience as an athletic trainer in the collegiate setting was that there was very much this culture um, around, particularly within collegiate football, which is where I spent a lot of my time, of not only hiding concussion, right, but and obviously also downplaying it. But I mean, I don't know what things are like, at Gustavus, but I'm assuming there's probably a little bit of kind of a culture of just kind of trying to downplay symptoms.
I feel like there's a bit of that too, but from my experience, at least it seems worse in high school
Yeah,
just because like by now like you kind of understand like you're not going to live forever and things are serious.
yeah,
So yeah, that's kind of my whole viewpoint on that, but
for sure. And yeah, you're absolutely right. I mean, and that's something that I dealt with too, like in a lot of like charity football games and stuff like that I worked. We had coaches from basically all over like rural West Texas, and the level of education in regards to concussion was really really bad. And some of the things that I heard them tell their teams and their players was ridiculous. Um, there was one year where one of the coaches told them not to complain about their heads hurting, and we were all standing there at practice and heard it, right? And anyway, but yeah. So, and that's why when we talk about when we get it as we're going to get into management on Friday and in the next week, and we're going to talk about the importance of educating stakeholders and particularly coaches, right? So this is one of our female. This is our one female participant in the study, and her situation was different, right? So she expressed a lot of anxiety, um, and her situation was also unique because she was 19, 20 years old, but she also had a 2-year-old, right? She had a daughter, and she, she essentially said, "Yeah, I've noticed, since my most recent concussion, I can't even." She had a lot of vestibular problems as well. I can't bend over to pick her up without getting really dizzy and getting headaches, right? I'm also I also get really really annoyed with her much more easily than I normally would, right? And so there are she's reported a lot of changes cognitively, particularly depression, and noticed having a harder time kind of reestablishing a normal mood, right? After her most recent concussion, at least uh, within the study, right? So, okay, so obviously, right? This is just essentially, the participants here talking about the tendency to want to just kind of like stay away from people, right, and kind of withdraw, right? And so this is Doug. Uh, Doug was a great Doug was a great dude, right? He said, yeah, during a concussion, I'm very to myself, don't really want to converse with anybody, and this is, Joe talking about her daughter and how quickly that she can get irritated, right? The normal, and then obviously and then you've got Adam down here, this guy. He had like 6 concussions. He had a pretty substantial history, right? And so for him, right, he said, well, I still want to maybe interact and do things, but I don't really have as much of a threshold, right, socially, and I kind of get tired a little bit more easily, and I just want to, kind of shut it down after a while, right? So, okay, when we talk about obviously, these symptoms, right? Obviously, fatigue, headache, depression, mood changes, these types of things are very, very common with cognitive presentations. Um, Obviously, we know that if we're going to be looking at activity levels, it's important to, kind of prescribe activity that doesn't exacerbate symptoms. How do we know that? Well, one tool that we can use, as long as symptoms allow, we can use our Buffalo concussion treadmill test to give the patient a guide as far as heart rate, right? For how much activity to do, level of exertion, these types of things, right? And so, as we'll talk about in management, right, it is extremely important, right, before we start the actual return to play process, for symptoms to be resolved, okay, completely for 24 hours or more prior to beginning gradual return to play. Okay. And we will review those phases and talk about that. Okay. Obviously, there are other things that we can utilize for cognitive strategies like we talked about. We have to have a lower threshold for referral in these cases, so referring to counseling for things like cognitive behavioral therapy, even just talking things out, right, with a counselor sometimes. The use of medications if needed, right? um, so antidepressants, anti-anxiety medications, whatever might be needed, and then making sure that people are getting enough sleep. So one of the things that people tend to struggle with, particularly if they have cognitive symptom profiles, is they may struggle with insomnia. They may either sleep too much or they may not be able to sleep. So utilizing maybe things like melatonin, these types of things that are known to be like sleep aids, can be helpful, right? And then obviously making sure that people are appropriately hydrated and have a good diet. And then, right, depending on the situation, even utilizing a little bit of what's called exposure therapy. So that but I should say, all of that needs to be essentially guided, right, with an experienced professional like a counselor or a sports psychologist, right? So that's not something that I would attempt to prescribe on your own. If you have a mental health team where you work, a counselor and or sports psychologist, I would utilize them, please. Okay, so just have that lower threshold for referral. So, all right, guys, nice job today. We got through 2 presentations, so we have essentially covered, okay, symptom clusters. So good job. We will tomorrow, okay.
Yes, I
Is
didn't
he
know if you
frozen
guys
for
were
you guys
frozen.
too?
Oh, I was just done.
Yes.
Yes.
Wade? No.
Wade,
Hello?
you there? Well, that was nice.
Do you think he'll just email us?
I don't know. It's a good question. I feel like you might come back, but I don't know.
All right, well, you guys have a great day.
You too, Izzy. See you, Bennett.